So I would like to acknowledge the land on which the University of Toronto Mississauga campus and Region of Peel operates on, which is part of the treaty lands and territories of the Mississaugas of the Credit. For thousands of years, it's been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. And today, this meeting place is still home to many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to work on this land. I'm also personally grateful to this land that has provided me with a place to live, work, and raise my family, and I recognize that this privilege comes from the stewardship and care of the Indigenous peoples who have lived here for millennia. So welcome everyone, and thank you for attending today's Network for Healthy Population seminar entitled From Data to Action in the Fight Against Diabetes and NCDs in Malaysia, presented by Dr. Li-Ling Lim, who has come to us, arrived last night from Malaysia. Welcome, Li-Ling. Before I introduce her, we'll just talk about some quick housekeeping items. So we'll appreciate that our audience who are online mute themselves during today's presentation. There will be opportunities for questions at the end of the seminar. You can either ask your questions through the chat or the raise hand function. We'll also take questions from our audience in the room. And lastly, today's session will be recorded, I think. Yes, it is. So we will make the recording available on our network website. So now I'd like to introduce you to our speaker, Dr. Li-Ling Lim. Professor Lim is a consultant endocrinologist and head of the Department of Research, Development and Innovation at the University of Malaya, Kuala Lumpur in Malaysia. She also holds honorary positions at the Chinese University of Hong Kong and the Baker Institute and Diabetes Institute in Melbourne, Australia. As a clinician scientist, Professor Lim's major areas of interest are cardiometabolic medicine, epidemiology, molecular, and implementation science, a lot of what we're doing here with the network. Professor Lim sits on the scientific work groups of the American Diabetes Association, as well as the EASD Precision Medicine in Diabetes Initiative and the World Health Organization Global Diabetes Compact. She's published more than 130 peer-reviewed articles, including papers in the Lancet, Nature, Diabetes Care, as well as Science Bulletin. And her H-index is 49, which is very impressive. Professor Lim has also received several awards, including the University of Malaya's top cited researcher in 2024, world's top 2% scientist by Stanford University, amazing, and the EFSD Albert Reynolds Fellowship, tenable at the University of Oxford in UK. She's an editorial board member of several Tier 1 Web of Science Index journals, and she's also the honorary assistant secretary of the Malaysian Endocrine and Metabolic Society. She was actually from 2022 to 2024, as well as the vice president of Diabetes Malaysia, and a country affiliate of the International Diabetes Federation. So without further ado, I'm going to pass it on to Professor Lim. Go ahead.
Thank you very much, Lorraine. Very generous introduction. Also, thank you very much to Calvin for bringing me from Malaysia to Toronto. Really great pleasure to be able to share with you some of the local data and statistics and what will be some of the diabetes prevention work that we're doing right in Malaysia. So the first thing is I'm really fortunate that during my PhD in Hong Kong, have been deeply involved in the Lancet Commission on Diabetes, and from there we actually came up with a framework. It's really important in order to transform care and patient life. You need to use high quality data. And diabetes is not only at the individual level. Diabetes, in order to transform care, we actually require a multi-component societal, community, and individual strategy. If we were to look into individual level, then most of us who are actually sitting here, even joining online, that we really envisage to strengthen the implementation of the integrated care teams. It happens at my center, it happens in Toronto. Then what about community level? We always say that diabetes is one of the NCDs and lifestyle changes needs to be there. And how we implement that at the community level, we tend to see inter-country variations. Health policies, we do have tobacco ban. We also have SSB tax. Malaysia is one of the few countries that have really implemented SSB tax since 2016. And we also have universal health coverage. It's a two-tiered public health system. 70% of our healthcare expenditure in Malaysia is actually subsidized by the government of Malaysia. In terms of a broader aspect, societal level, there's a need for intersectoral policies. We're talking about climate change, we're talking about environmental health, and again, health equity, reduction of the health disparity is equally important. One thing that Malaysia is facing is we actually need more effort to improve health literacy. It's about 20% of the Malaysian population has been really good in health literacy, and improvement of preschool and school education will take time. But there is some policies that the government of Malaysia is really looking into from our national strategic plan. So showing you here would be the 16 high-income countries where I try to look into the death rates due to any causes among people with type 2 diabetes. And just want to remember, in a year, within these 16 high-income countries, you need to treat 10,000 patients, up to 350 of them would have died due to any cause. But do we see the same in Malaysia? This is a collaboration between our institution with the Ministry of Health Malaysia. We look into the National Diabetes Registry, close to 1.8 million of people. But mainly the limitation of this would be is only publicly funded primary care clinics. And showing you here, one of the results would be stratification by the cardiovascular status. The left-hand panel would be type 2 diabetes without prior cardiovascular disease. And on the right-hand panel will be type 2 diabetes with prior cardiovascular disease. And the top bar would be female. And the bottom panel would be male. The green line will be the diabetes population, the death rates, and in comparison to the general population will be represented by the red colored line. So if we were to compare to the 16 high-income countries, type 2 diabetes without prior cardiovascular disease, in fact, is actually high. Up to 400 men with type 2 diabetes will have died among 10,000 patients in a year. Then what about those with prior cardiovascular disease? In fact, it's about 2 times higher than what I presented just now, the average from the high-income countries. So I didn't show you another slides. It's open access, so you can actually try to download if you're really interested with that. We also saw an increasing death rate due to any cause for people with type 2 diabetes with a longer disease duration, more than 10 years in Malaysia. This in the public healthcare primary care population. So have we not doing enough? Looking at this, the mean HbA1c is about 8%, and the mean LDL cholesterol is about 3 millimole per liter, and the mean BMI is 28. It's pretty similar to the average of 30 kilograms per meter square that we saw for Western population. And in fact, despite the use of organ protective medications, they will be the older generation, RAS inhibitor and high even statin. 70% of them, they have been covered and optimized with RAS and statin, but in fact, we still see a plateauing trend of the death rates due to any cause, and those with longer disease duration, those with prior cardiovascular disease, in fact, the trend is actually increasing. So how are we going to use the data? Because we have visualized the gaps, saying that the death rates due to any cause among people with type 2 diabetes, they are not declining, just like other high-income countries. So one of the things, the easiest among the glycemia, blood pressure, cholesterol, and adiposity, the easiest for us to treat is actually cholesterol level. The mean LDL was 3.1, I've shown you just now. So we tried to prove to the government saying that if we target those with type 2 diabetes and uncontrolled LDL cholesterol, we just reduce the LDL cholesterol by 40% irrespective of the strategies. You want to use the early combination, you want to use the PCSK9 targeted therapy. And looking at that, in 10 years, we were able to avert up to 330 new cases of atherosclerotic cardiovascular disease and death. And similarly, from this, it will be translated to a reduction of direct healthcare costs, close to $2 billion US, and we also will be able to experience a similar yield in terms of productivity, just by targeting the low-hanging fruit, intensification of the cholesterol level. So using this is based on our population-based health surveys as well as the hospital-based data, the target type 2D, and now from these postulations of the health economic analysis of the Ministry of Health, most of the primary care clinics actually transition from a moderate intensity statin to high intensity statin with an early combination, providing better access of the intensification platform. So do we see any other key gaps in the NCD care in Malaysia? One of them will be early onset type 2 diabetes. I believe this is also a similar research interest among the group who are actually sitting here. This from the NCD risk factor, purposely age 20 to 39. Out of the 20 countries in the world, Malaysia actually ranked 13 of the 20 with the highest rate of the early onset type 2 diabetes. And one of the factors because of the overweight and obesity pandemic, showing you here will be transition from 1990 until 2022 over 3 decades. So the red color will be the obesity and the blue color is actually underweight. What I've highlighted here will be Southeast Asian countries, including Malaysia. 3 decades ago, we have more underweight, but 3 decades later, we actually have a higher degree of obesity. So the nutrition transition over the past 3 decades actually also influenced by the rapid urbanization. So why are we seeing all this high rank 13 out of 20 at the global level for Malaysia in order to have early onset type 2 diabetes? There are actually a few hypothetical models. Number one is you have the model A would be you just have the age of diabetes onset, just genetically predisposed, and hence actually leading to the much higher risk of developing type 2 diabetes before the age of 40. The risk factors will actually be for the hypothetical model A. It has been present even at the beginning. For example, you have high cholesterol, but this has not been treated, or you have hypertension. And the model B would be, what if you just have high cholesterol or even adiposity, which develop at a later age, but it's rapidly progressing. And this will have led to the earlier age of onset of diabetes as well. The model C would be tend to happen in Malaysia because most of the Malaysians, they tend to have a clusters of cardiometabolic risk factors. So once they diagnosed to have dysglycemia, whether it's a pre-diabetes or over diabetes, they tend to come together with overweight and obesity. They tend to come together with hypertension and cholesterol. So all these clusters of risk factors will have led to the early onset of type 2 diabetes. And the model D would be, as what we know, that Asians tend to have a genetic predisposition to the beta cell dysfunction, which is present in the gray chart area. And once they have been hit with just a single risk factors, single cardiometabolic risk factors, this will perpetuate the earlier onset of diabetes. And one of the fact that we are also anticipating really another wave of early onset type 2 with multiple complications. The MLTC tend to happen, putting aside what I mentioned just now at the top left, tend to have a clusters of cardiometabolic risk factors. They also have the typical diabetes-related long-term conditions, something that we tend to call it together CKLM, the cardiovascular, kidney, chronic liver disease, and even other traditional microvascular complications. But in fact, we tend to see they come to us with other associated long-term conditions that will be on top the right panel. They may have autism, they may have physical disability, and mental health tend to happen even more right now with anxiety, depression, and even they also tend to drop out from their workplace or even from their universities or school education. So I've told you about early onset type 2 diabetes. We are also seeing this trend, and in Malaysia, they have a higher risk of complications. They also have a higher risk of premature mortality. And, apart from how are we going to recognize them and how do we bring them back into the healthcare system, we need to understand why do they have that. It actually comes with multiple drivers. So putting aside the cardiometabolic risk factors that I mentioned just now, we also need to look into the aspect of social determinants of health. Rapid urbanization is actually happening in Malaysia. Is an upper middle income country, and most likely next year we will transition into the high income country. And some of these socioeconomic status I've mentioned, health literacy, mental health intersections, and access to healthcare. Even we have universal health coverage, but we do not have a mandatory social health insurance. And the personal health insurance is actually optional. So it depends. Some people, especially a lower middle income group, they do not have insurance coverage and very much reliance on the government subsidy for the access to healthcare. And again, to strengthen, to highlight the point that the health awareness program, the penetration, it can be low. And hence both our institutions under the Ministry of Higher Education, together with the Ministry of Health Malaysia, we have actually changed some of the strategies for the health awareness campaigns that I will show you afterwards. So how are we going to use data to drive actions in Malaysia? And what we have done so far in the past few years is by using the gap visualizations of the epidemiological data. So I've shown to our policymakers that yes, we know that diabetes is on the rise, but they are yet to know that all-cause diabetes are not declining. And from the collaboration Ministry of Health, the article, we really trigger our policymakers saying that despite of what we have done in the past 3 decades, in fact, our people with type 2 diabetes still die. Okay. And another key determinants would be there will be increasing incidence of early onset type 2 diabetes. This is another wave with high risk of complications, and they die prematurely. And we also saw health inequality in terms of all these people. And because of this, whether you are looking into late onset or looking into early onset, because care, even though I say that they do die, but in fact, the care also improve over time, access, availability, just that it's not as fast as what we have expected. So multiple long-term conditions are actually emerging. And because it's such a heavily subsidized healthcare system, so we do expect there will be increasing burden of the government subsidy because of the higher direct as well as the indirect healthcare costs. Because imagine when we have more younger people developing type 2 diabetes, the productivity level will have dropped. And again, because Malaysia is a multi-ethnic country, 70% actually of Malay ethnicity, and about 25% is because it is Chinese ethnicity, and about 10 to 15% would be Indian. We do have a certain proportion, a small proportion of indigenous population. So everyone is not the same. So tend to have heterogeneous disease trajectories. We do see differential in terms of treatment target attainments. We also see differential risk in terms of the predisposition to the complications. And hence, it's really important that we have specific, more precision approach to identify the right patient in order to deliver the right treatment at the right timing. So talking about the precision health, this is also another move by our Malaysian government, similar to our institutions, because we recognize that the differential sources of heterogeneity, it could be due to the differential internal diagnostic approaches. Of course, very little is because of the observer error or analytical error, but in fact, genes are different because we have higher early onset. We also experience at a higher degree of gestational diabetes with the epigenetic modification, and all this we have integrated with multi-omics pathway leading to differential heterogeneity of people living with type 2 diabetes. And then when we talk about that, there are actually 4 pillars. We're not only looking into genetic biomarkers, we also want to look into the non-genetic biomarkers, where hopefully all this will come together for early diagnosis, then timely prevention, and we have appropriate and adequate prognostication of their trajectories, and ultimately is the personalizations in terms of their treatment. And how we actually look into by involvement in some of the global network. This is one from the NIDDK Heterogeneity of Diabetes Global Meeting, and we managed to get to all this knowledge that we garner from the global network meeting, trying to tell our Ministry of Health together with other government policymakers, apart from community work, we also need to look into establishment of the precision medicine network. And this has been done and has been suggested in the technical work group for diabetes as part of the upcoming 5 years of the National Strategy Plan for NCD in Malaysia. So with funding from both local and international funders, I've set up the Melody, which is the multi-ethnic lifestyle, obesity and diabetes registry and biobank in Malaysia, purposely looking into the multi-ethnic populations, looking into early onset type 2 diabetes and their disease trajectories over time. And I'm really fortunate to have a group of team, regardless whether they are clinicians, whether they are allied health personnel or even students, and trying to cultivate their passion and enthusiasm. Really, apart from clinical excellence, we're also looking into research innovations, and all this research will be able to transform care. So as mentioned, this is one of the community NCD awareness and screening activities that we've done since 2022. This is from an institution, because in order to make people attend campaigns, we found that there's actually a lot of dropout rates. So we have done a few community screening drive, whether just within our diabetes care unit alone. We also partner at the hospital level together with the other ministry that we go out of our institution. And usually those areas out of the Klang Valley or the Greater Kuala Lumpur region, we tend to go to rural and suburban areas, because we know that usually those with a lower health literacy, those who have inadequate access to healthcare, they actually being parked over there. And one of the things that wish to get insights from the one of this network of healthy population would be, we found that once we have screened those with pre-diabetes, because when we screen, we actually use the point of care of HbA1c, we won't be able to do OGTT during the screening drive. And we actually asked them to come back. And Ding, my fellow, actually presented at IDAC this year. We have 80% of dropout rate when they should go to any of the healthcare facilities, whether it's the primary care or secondary or tertiary care, to get the 75 gram of OGTT done. So 80% dropout. We only managed to catch 20% of these people. So really good if we manage to hear from Lorraine and your team that how we actually curb this challenge. So with that, that will be the end of my presentations of so far what we have done in order to use using epidemiological data to inform some of the practice change and policy change in Malaysia. Thank you very much.
Wonderful. Wonderful. We'll sit together. It's okay. Come. Yes, thank you so much, Li Lim, for such a great presentation. And really, it's remarkable the amount of work that you've done in Malaysia to sort of help to understand the epidemic and tackle the epidemic of diabetes that we're seeing everywhere, really. So maybe I'll open it up for questions. If anyone in the room or online has a question. Let's see, are we able to see if somebody's, maybe we'll stop sharing. Okay. Maybe while people are thinking, maybe I can ask you, so one of the big challenges around the world is really with data, right? So you've got this diabetes registry. Can you tell us a little bit about how that registry was developed? What, where are your sources?
Okay. So the National Diabetes Registry was actually developed by our Ministry of Health Malaysia. So we target the publicly funded primary care clinics. So far, to date, we have 1.8 million of people with diagnosed type 2 diabetes have been registered into the National Diabetes Registry. So it was set up since 2013. Okay. Yes, 2013. So we have about 1,200 primary care clinics who contributed data to the National Diabetes Registry. And every year, that way we call it the registry data set. And every year, randomly, we actually select a certain proportion of people to have the additional audit of the clinical complications, clinical events. And this is actually done periodically on an annual basis. Usually it's between July to August of each year. And from there, certain limitation with regards to the National Diabetes Registry would be the events actually tend to be self-reported. Self-reported. Okay, yeah. There'll be certain that if they manage to adjudicate using electronic portal, that would be good. I take a step back is because the primary care clinics under the Ministry of Health Malaysia, not all actually have electronic medical record system.
So then you won't capture them.
Then you won't be able to capture. So that may come as a self-report. But when we actually use all this, and of course with the advancement in terms of diabetes care and the guideline-directed medical therapy, and we realize there's a need for us to do two things with regards to National Diabetes Registry. The first thing is to expand it to other public hospitals, okay? Because we only capture primary care. We also need to capture hospital-based patients. And then second, it will be there's a need to revamp the entire electronic portal of the National Diabetes Registry to capture the use of SGLT2, the use of GLP-1 receptor agonist-based therapy, because it has not been done.
I see.
Yes, yes. So this two newer generation of GDMD, they usually classified under other medication. And work is in progress because it has been there's an additional budget that's just recently released at the Parliament of Malaysia. So the Ministry of Health is getting a certain high amount of the budget to revamp the National Diabetes Registry to be more apt to the current trend of the diabetes care.
That's great that you have the leadership from your Ministry of Health to do this. This is something we're working on here in Canada.
Few years.
Yeah, I'm sure. I can imagine. So you say it's primary care publicly funded. What proportion would be missed who seek care through private organizations?
Okay, so in terms of the outpatient, the Ministry of Health clinics, including hospitals, they have captured 70% of the diagnosed diabetes population.
Okay.
Yes, but hospitalization would be slightly different. Hospitalization, 60% would actually have private. Yeah.
Okay, that's okay, good. So you'll get more. Go ahead, Calvin.
Yeah, thank you for the talk. It's really great to hear the excellent work that you've been doing, and so happy that you're able to make it to Toronto to share that with us. I have a couple of questions. You mentioned that you showed how Malaysia has one of the highest rates of diabetes prevalence in the world, and certainly the highest in Southeast Asia. And in the context of Malaysia, you mentioned possibly transitioning to a high-income country. Do you have a sense of what the unique factors are in Malaysia that lead to such a high rate of diabetes? And then the second question, I was intrigued by the target of LDL reduction being sort of a more easy to achieve target compared to more complex targets that may require more intervention, like glycemic targets, the 40% reduction. So can you talk about how you envision that could be achieved in terms of the care processes? What the process of are there any practice guidelines, and what the coverage is for those people who are on medications? How is that obtained?
Thanks, Calvin. So answer to the first question would be, main thing is still lifestyle. Okay. It is not so pedestrian friendly in Malaysia. Okay, this is one thing. Second thing is we do not have a nice fall just like in Toronto. It is hot. Slightly better than Bangkok. Okay. And third is similar to other Asian countries, Malaysians tend to have a high carbohydrate dense diet. Food environment, healthy food environment is available, but it's not readily accessible. Okay, and hence there are a few nutrition interventions that be done by our in nutrition department. They try to, it is short-term, mid-term, and long-term. So they include nutrition labeling. They try to have awareness campaign teaching the public how to read nutrition label. Then we do SSB tax in order to tax the providing incentive for industries who actually manufacture the healthier food choices and beverage choices. And of course, education still needs even longer time than the current ones. So we start to see some uptake in terms of the healthier food selection, but it still take more time. The third thing, it would be the environment is still the same. Okay, because 1 in 2 adults more than 18 years old in Malaysia has a BMI of more than 25. And they don't feel that they are different. And so all this will have contributed to the high burden of diabetes or even obesity in Malaysia. And the fourth will be stigma. Because when you're 1 in 2 having overweight and obesity, some of them, so I will say not some, 70% of them, when they turn up to our clinic, they actually mentioned that they have actually failed lifestyle intervention attempts and they actually need additional intervention. And most of them, quite slightly different compared to guidelines. Guidelines, when we manage people living with obesity, they will say that we have to really force to try for the 6 months of the lifestyle intervention. If they feel that, then only you intervene with GLP-1 based therapy or even intervene with the MBS, metabolic bariatric surgery. But our experience of managing this group of people, we just need to make it as a reverse. You have to make them lose weight first. Then they feel more motivated in order to maintain with a healthier lifestyle. We can't, 10 years ago, my institution tend to have obesity clinic, but we face it up because people with obesity will turn up to that clinic during that time. They were exhausted, they were disappointed, and they have been demotivated because every time when they turn to the clinic, it's either lifestyle or surgery. Even though they've told us saying that, no, I really failed it. And then really, it works in Malaysia that with a better access to GLP-1, it tend to offer hope to this group of people. And we do see that really they lose 10 to 20% of body weight. And they even tell you right now, they feel healthier, lighter, they're able to exercise, and they even try to maintain whatever they've lost by practicing healthy lifestyle. So this is one key thing that we hope that it will help to transform the trajectories of the diabetes and obesity burden in Malaysia. Answer to your second question is with regards to the lipid lowering. So first way it would be they have actually phased out moderate intensity statin. Previously, the publicly funded primary care clinics, they only have access to simvastatin. Yes. And only happened about 3 years ago. Yeah, they start to phase out moderate intensity simvastatin and change it to the higher intensity statin with a different ranges, so you can make it as moderate or high. And we also have the drive to educate healthcare providers, saying that this is easiest amongst the 4 types of the risk factors actually seeing. So our clinical practice guideline did mention specifically is similar to the ESC categories. If it's a type 2 diabetes, a minimum 2.6 and below. If the high risk is 1.8, the very high risk is 1.4. So we have to reiterate the need of looking into intensification based on the cardiovascular risk. So we highlighted the need to be updated with regards to the cardiovascular risk stratification among people with type 2 diabetes, because that will actually guide the treatment intensification. And hence, most of the private lab who are actually offering health screening packages, instead of putting less than 2.6 as a standard cutoff point for LDL, they have started to put additional based on your cardiovascular risk. If you are low, moderate, high, or very high, it should be as such. And the resistance from people with type 2 diabetes would be less. Okay, I believe you might feel so because they have so much myth about statin, and they do not want to get it intensified because the lab has shown you saying that it's less than 2.6. Why are you asking me to get it down to 1.4?
Yeah.
Yes,
you have to get collapsed.
so these will be certain changes that we have seen in the past few years.
And are medications generally publicly funded for people who are in the public system?
Yes.
And are there
Heavily subsidized.
really, like
Yes.
including the newer agents like SGLT2 and GLP-1?
So SGLT2 happened in my institution. So if it's a civil servants, then it is free, subsidized. If you are private, then it's self-pay. But it's at the lower rate compared to a full private. So if it's at the Ministry of Health, they make it as a quota system. For example, a primary care clinics, a year they may be only allowed to prescribe it for 100 patients. But generic has come in. And
for the SGLT2.
Yeah, for the SGLT2. For GLP-1, in fact, our Ministry of Health doesn't have GLP-1.
Okay.
It's only available in university hospitals.
Okay, and then subsidized?
Subsidized if it's a civil servant.
Right. Okay, so a little more limited.
Yes.
Yeah. So, but how often do people have private insurance then to cover their medications?
If it's a young working population, usually they would have had
Okay.
personal health insurance, but health insurance will only reimburse for type 2 diabetes, etc., for GLP-1. If it's for obesity, no.
Right. It's
Similar.
Yeah. Do we have any other questions? I think if we don't, maybe we'll end a little bit early so you can have some lunch and a little bit of rest. But we want to please join me in thanking Professor Lim for a wonderful presentation, and thank you to those online. And so we want to make sure for those who were attending to please complete today's evaluation. And please join us for our next seminar, which is going to be on November 17th, 2025. We'll have Rayshawn White's presentation, where she'll talk about the critical gap in race-based healthcare data in Ontario. And we'll send out a flyer, so please look out for it. Thank you very much, everyone.
Thank
Hope to
you.
see you there. Bye-bye.